So our group project was over Mycobacterium leprae. And the morphology of Mycobacterium leprae is that they're bacilli or rod shape. The bacteria usually appears in clusters under the microscope, and they appear either slender, curved, or straight. The microbe is intracellular. The size of M. leprae is usually 1 to 8 micrometers in length and 0.5 micrometers in diameter. M. leprae is an acid-fast, gram-positive microbe with a doubling time of 14 days. M. leprae are non-sporing, and there is no capsule surrounding the bacteria. The cell wall has a thick peptoglycan layer, but it is also composed of unique types of lipids. The ends of the cells are rounded, and each sides of the cell are parallel, and the cells divide by binary fission. The primary carbon source for M. leprae is lipids. M. leprae has a large hydrophobic shell that prevents polar molecules, such as germicides, from entering the cell. The mycolic acids are very large lipids that usually range from 60 to 80 carbons long, and they are bonded together by covalent bonds to form a thick solid at room temperature.
For pathogenesis, Mycobacterium leprae is the bacteria that causes leprosy or Hansen's disease. Leprosy is a chronic granulomatous disease affecting the skin and peripheral nerves. The bacteria are slow growing, and the incubation period is an average of 5 years, but can vary from 3 to 15 years. Signs and symptoms can take up to 20 years to appear, but on average show up between 2 to 10 years. M. leprae has the longest doubling time of any studied bacteria. Next slide. For virulence factors, the first one is waxy exterior. The bacteria in the Mycobacterium genus are defined by their waxy exterior coat. In M. leprae, the exterior allows for intake into the macrophage and phagocytosis. The second one is macrophage invasion. M. leprae survives and replicates in macrophages. The bacteria prevent phagosome and lysosome fusion to avoid degradation. The third one is Schwann cell invasion. The major target of the bacteria are Schwann cells. The optimal temperature of the bacteria corresponds to the temperature in the peripheral nerves. M. leprae gets access to the cell through the lymphatic system and blood vessels. The infection remains localized to the peripheral nervous system by rolling and binding to expose Schwann cells. And finally, drug resistance. M. leprae has many mechanisms of drug resistance to allow it to continue to survive.
For disease development, Mycobacterium leprae enters the nasal and alveolar epithelial cells. From there, the bacteria travels to the nasal septum and can then travel to the lungs. Mycobacterium leprae replicates intracellularly inside histocytes and nerve cells and has two forms, tuberculoid and lepromatious. Tuberculoid is one form that induces a cell-mediated response that limits growth. Through this form, M. leprae multiplies at the site of entry, usually the skin, invading and colonizing Schwann cells. The second form of leprosy is the lepromatious form, which is when microbes proliferate, which means they increase rapidly in numbers within the macrophages at the site of entry. They also grow within the epithelial tissues of the face and earlobes. Cell-mediated immunity is an immune response that does not involve antibodies, but instead phagocytes and antigen-specific cytotoxic T lymphocytes. Since cell-mediated immunity is damaged, large numbers of M. leprae appear in the macrophages, and the infected patients develop papules, which are skin-raised bumps on the skin at the entry site, marked by a folding of the skin. Extensive penetration of this microbe can lead to severe body damage, like the loss of fingers and toes. Next slide. Signs and symptoms are light-colored or red skin patches, growth nodules on the skin, painless swelling or lumps on face or earlobes, enlarged nerves, reduced sensation, numbness, and weakness in hands and feet could lead to paralysis, painless ulcer on soles of feet, eye problems could lead to blindness, weight loss, pain in joints, stuffy nose, and nosebleeds. The short-term and long-term effects. Short-term effects include many common symptoms like skin patches, growth nodules in skin, and joint pain. Some long-term effects are granulomatous disease, which is an immunodeficiency disease that increases the body's susceptibility to infections. Also, anesthetic skin lesions and nerve damage. Nerve damage is signaled by a burning sensation in the arms or legs. Damage to nerves makes it harder to control muscles. It also causes weakness. Mycobacterium leprae does not cause apoptosis or any cytopathic effects. Cells usually respond to liposaccharides or endotoxins by inducing apoptosis or cytopathic effects. None of the above was observed when myelinated cultures were treated with M. leprae cell walls. The only thing noted was demyelination and axonal damage. Next slide.
A lot about the transmission of M. leprae is still unknown. Known reservoirs are humans and armadillos. Armadillos are considered to be naturally infected by the bacteria, and it's recommended that contact be avoided. Leprosy is not highly contagious and can only be spread through prolonged close contact with an infected individual. Known methods of transmission are through the skin and the upper respiratory tract and nasal mucosa. The countries with the highest number of cases and the most at risk are Brazil, India, and Indonesia, with 10,000 plus new cases annually. Next slide.
So for the diagnosis, there are a couple of avenues that medical professionals can utilize to diagnose Mycobacterium leprae. Some of these include an observation of clinical symptoms and signs, acid-fast staining, serological testing, analysis of skin or nerve biopsies, an immune response analysis, or skin smear analysis. Some of the specific tests that can be performed in the laboratory to determine if the microbe is Mycobacterium leprae would include an acid-fast positive stain, a positive Grand stain, and morphology analysis under the microscope, confirming that the morphology is bacilli. Next slide. Furthermore, signs and symptoms that medical professionals can observe to diagnose Mycobacterium leprae can include discolored skin, muscular weakness, loss of feeling in affected areas, nerve inflammation, dry or unusual skin textures like a hardening of the skin, ulcers which can appear on the bottom of the feet, swelling in the face or ears as seen in this picture, hair loss, paralysis, and difficulty seeing. There are two different severities of Mycobacterium leprae. One includes Pauci bacillary, which means that there are less than 5 skin lesions, and within a skin smear result, it would be negative for the presence of bacilli. The other severity, which is worse, would be multibacillary, which means there are more than 5 skin lesions, and within a skin smear result, it would be positive for bacilli, the presence of bacilli. Within the period of treatment, Mycobacterium leprae can also lead to reactive episodes. These can present as inflammation of current lesions, further swelling or reddening of the skin. In cases of MB or the more severe presentation of leprosy, erythematous nodules can appear, combined with fever and further inflammation of the person's skin tissues. Next slide.
At this time, there are no preventative strategies provided by the World Health Organization. However, since the 1990s, there has been research performed on different antibiotics and multi-drug therapies. The Guideline Development Group through the World Health Organization recommends chemoprophylaxis with a single dose of rifampicin as a preventative treatment for anyone who has been in physical contact with a leprosy patient. Programs are also in place to help screen for those who have been in contact with a leprosy patient. A randomized controlled trial showed effectiveness of a single dose rifampicin over the course of 5 to 6 years. For every 1,000 contacts that were treated, 4 cases were prevented after 1 to 2 years, and 3 cases were prevented after 5 to 6 years. In 2016, the World Health Organization presented its global leprosy strategy to take steps toward control of leprosy. This strategy is broken down into 3 pillars. The first pillar targets strengthening government ownership, coordination, and partnership through 1, ensuring political commitment and proper availability of resources to leprosy programs, 2, contributing to universal health coverage, specifically for women, children, and underserved populations, 3, promote state and non-state partnerships and promote national and international collaboration, 4, facilitate operational research in all aspects of leprosy. And 5, strengthen surveillance and health info systems to monitor programs. The second pillar provides goals to stop leprosy and its complications by 1, increasing patient and community awareness of leprosy, 2, promote early detection with campaigns directed towards contact management, 3, ensure timely treatment, compliance with treatment, and improvement being made towards new treatments, 4, improving of prevention and disability management, 5, strengthen surveillance and antimicrobial resistance, 6, create new approaches for training on leprosy, and 7, promote prevention interventions. Lastly, the third pillar aimed to stop discrimination and promote inclusion by 1, addressing the stigma and discrimination about leprosy within society, 2, empower those by leprosy and connect them to all available resources, 3, include the community in strengthening leprosy services, 4, promote access to both social and financial support services, 5, encourage community-based rehab for those with leprosy-related disabilities, and 6, work towards abolishing discrimination laws and include all who are affected by leprosy. The targets of this global leprosy strategy include 1, 0 disabilities among new pediatric patients, 2, a grade 2 disability rate less than 1 case per million people, and 3, 0 countries with legislation allowing discrimination on the basis of leprosy. In addition to this strategy, in 2017, the World Health Organization published the Monitoring and Evolution Guide, and in 2018, they published guidelines for the diagnosis, treatment, and prevention of leprosy. Unfortunately, to date, there is no vaccine for leprosy. For such an infectious disease, a highly effective vaccine would be required in order to eliminate it from the population. Trials are still needed for new and existing vaccines. One vaccine called LepVax is currently in stage 1A of testing. Few countries around the world, specifically India and Brazil, are using Bacillus calmette-guerin, or the BCG vaccine, as both a tuberculosis and leprosy vaccine. This is a live vaccine containing a weakened form of the M. tuberculosis organism. This vaccine, used for both diseases, is justified because these two diseases are caused by similar microbacterial agents. With that being said, the effectiveness of this vaccine for leprosy is widely disputable because although there are some similarities between the two, including similar cell walls, enzymatic capabilities, and number of molecules, there are significant chromosomal sequence and gene capability differences. The United States and other countries are still working to develop a universally accepted leprosy vaccine. We are unsure when a vaccine will be developed in the United States due to the low incidence of leprosy patients here, and approximately 90% of cases are brought in by immigrants who come from countries where leprosy is an endemic. Because of this low incidence, there is little value in utilizing resources to develop a vaccine when patients, once diagnosed, can be treated and cured with antibiotics within 6 to 12 months. The key strategies for reducing the burden of leprosy caused by Mycobacterium leprae include 1, early diagnosis, and 2, MDT or multi-drug therapy. The MDT or multi-drug therapies are outlined in the table on the slide. This table is broken down into 3 age groups: adults, children ages 10 to 14, and children under the age of 10. For each age group, the antibiotics remain the same, including rifampicin, clofazimine, and dapsone. Rifampicin and clofazimine are dosed once per month, and the dapsone is taken daily. The doses vary per age group. As mentioned earlier, leprosy is broken into 2 stages, MB and PB, based on the number of lesions present on the body. The stage determines the duration of the treatment. This is outlined in the right-hand side of the chart.